Okay, let's jump straight into a rapid-fire, high-stakes clinical simulation covering the exact temporal threat matrix of subarachnoid hemorrhage. Welcome to this explainer. If we're going to hit that perfect 280-plus board score and achieve true top-tier clinical mastery, we have to look way beyond just managing a bleed. We are navigating a highly predictable but incredibly dangerous chronological minefield. So let's dissect these intricate mechanisms and discrete management steps together.
Rather than a standard textbook overview, we are jumping right into the ticking clock of SAH complications. In this scenario, the timeline is your absolute guide. The primary threat literally transforms based on the hour. Think about it. In the first 24 hours, the battle is strictly against a catastrophic rebleed. Then, from day 3 to 10, the field shifts entirely to the ischemic threat of vasospasm. And weeks later, that's when we see the silent onset of communicating hydrocephalus. The day of onset isn't just a detail, it's our ultimate diagnostic key.
So when a patient presents with the classic worst headache of life, that intensely painful thunderclap, the absolute first move is a non-contrast head CT. What we're looking for is acute blood tracking directly into the basal cisterns, outlining the major proximal cerebral blood vessels arising from the circle of Willis. It'll show up hyperdense, bright white, and it signals a massive, immediate medical emergency.
But what happens when the clinical picture is absolutely screaming subarachnoid hemorrhage, but the CT scan comes back completely clean? Surprisingly, this actually happens quite a bit if the bleed is small or maybe a few days old. If that CT is falsely negative but your clinical suspicion remains high, the mandatory next step is a lumbar puncture, and we are hunting strictly for xanthochromia. This yellowish discoloration of the CSF is caused by red blood cells breaking down into bilirubin. It's our definitive, unarguable proof of a bleed.
Now, back to our timeline. During days 0 to 1, the absolute highest cause of mortality is aneurysmal re-rupture. The clot forming over the aneurysm is incredibly fragile right now. This dictates a strict hemodynamic mandate. We must aggressively maintain the patient's systolic blood pressure strictly under 160 millimeters of mercury. Any spike at all can blow that clot, leading to a rapid coma. We usually achieve this tight control using intravenous antihypertensives like labetalol or nicardipine.
Okay, once we secure that strict blood pressure control, we bridge immediately to definitive intervention. The patient must undergo 4-vessel angiography. This is crucial because it isolates the exact location and anatomy of the vascular malformation, which is typically a saccular or berry aneurysm. Finding this source is the absolute prerequisite for neurosurgical intervention. From there, the aneurysm is secured via endovascular coining or surgical clipping to permanently neutralize that rebleeding threat.
Notice how tracking the timeline isolates completely diverging presentations. For instance, if your post-op patient suddenly slips into a coma on day 1, the timeline strictly dictates this is a rebleed until proven otherwise. However, if that exact same patient develops a new, gradual onset focal neurologic deficit, say arm weakness or expressive aphasia on day 6, the mechanism has fundamentally changed. We're no longer dealing with a bleed, we are dealing with profound ischemia.
And that brings us to the ischemic catastrophe phase of days 3 to 10, where we face our secondary threat, vasospasm. What happens is the breakdown products of the subarachnoid blood fiercely irritate the cerebral arteries. This triggers massive spasms that literally cut off blood flow and cause strokes. Because this is the major cause of delayed mortality, there is an absolute non-negotiable medical mandate for all SAH patients: continuous prophylaxis with nimodipine. This highly lipophilic calcium channel blocker has to be given for a full 21 days to prevent delayed cerebral ischemia. No exceptions. Now, if the patient survives those immediate threats of rebleeding and vasospasm, you still have to anticipate the late-stage complication. Weeks to months later, those exact same subarachnoid blood products will strictly clog the arachnoid granulations. This completely halts the reabsorption of cerebral spinal fluid, which in turn drives a communicating hydrocephalus. Clinically, you need to watch for the classic triad: gait instability, cognitive decline, and urinary incontinence. It's an entirely different mechanism that requires an entirely different intervention, like a ventriculoperitoneal shunt.
All right, let's put this matrix to the test with a master case designed for deep clinical integration. Imagine you have a 55-year-old male who suffered a ruptured anterior communicating artery aneurysm. He underwent successful endovascular coiling on hospital day 1. Today is day 5. Suddenly, he develops profound right-sided weakness and expressive aphasia. His blood pressure currently sits at 130/80. You get a stat non-contrast head CT, and it's dangerously reassuring, completely stable with 0 new hemorrhage and totally normal ventricles. So what is the definitive diagnostic or therapeutic next step?
Let's lay out the clinical blueprint. We have 5 highly competitive options here, specifically designed to aggressively tempt you into a management trap. A. Immediate surgical re-exploration. B. Placement of an emergency ventriculostomy. C. Intravenous anti-epileptic administration. D. Transcranial Doppler ultrasound and induced hypertension. Or E. Intravenous alteplase or TPA administration. Take a second. Map the timeline and those completely stable imaging findings to this sudden clinical collapse.
Let's bypass the traps. Option A, surgery? Incorrect. The stable CT with 0 new hemorrhage proves the coil is perfectly intact. This is absolutely not a rebleed. Option B, an emergency ventriculostomy. Also incorrect. The normal ventricles definitively rule out acute hydrocephalus. Option C, anti-epileptics. Well, they won't do a single thing to reverse an ischemic focal deficit. And option E, IVTPA, is a fatal trap. Recent subarachnoid hemorrhage is an absolute contraindication for thrombolytics. That strictly leaves us with option D. By mapping the day 5 timeline in the stable CT, we definitively diagnose cerebral vasospasm. The definitive next step is a transcranial Doppler to assess severe vessel velocity and inducing permissive hypertension to forcefully push cerebral perfusion right through those spasming vessels.
So as you hit the wards or tackle these high-stakes scenarios, always ask yourself, when a clinical picture suddenly darkens, are you merely treating the symptom or are you treating the actual timeline? In neurocritical care, the symptom is just the alarm bell. The day of onset tells you exactly what is on fire, but it really begs a larger question. How many other acute pathologies are hiding behind a rigid temporal mask, just waiting for us to misread the clock? Keep pushing your clinical boundaries, and I'll catch you in the next explainer.